This oversight hearing for the Subcommittee on Health will now come to order. It's not often in Washington, D.C. you start very early in the morning shoveling snow, but thank you all for making it despite the snow. I understand this hearing focused on community care has garnered significant member interest, including from committee members who are not on my health subcommittee. So before we get started, in accordance with Committee Rule 5E, I ask unanimous consent that all off-subcommittee members be permitted to participate in today's committee hearing. Without objection, so ordered. As a 24-year Army veteran and a healthcare provider, I've seen firsthand the struggles our veterans face in accessing the care they have earned. I've also experienced the challenges providers encounter when trying to deliver the care. Let me make two things perfectly clear at the start of today's hearing. Veterans should never have to fight through a maze of bureaucracy to get the health care they deserve, and providers should not be bogged down by administrative hurdles just to serve them. These two statements shouldn't be considered partisan. This subcommittee has received multiple reports regarding delayed referrals, canceled appointments, lack of reimbursement, and long wait times for treatment that should be available much sooner. These aren't isolated incidents. These are systemic failures that have real harmful impacts on the everyday lives of veterans. And let me also say that I know that the VA is working very hard and very diligently to serve our veterans and to remedy these incidents. And it's why today's hearing is so important. Today is our follow-up to our previous full committee hearing, where we heard directly from veterans and their families about the barriers they experienced in accessing community care. But with the new administration comes new opportunities, and under the leadership of Secretary Collins, I have total confidence that the VA will course correct the failures of the previous administration to protect healthcare access for veterans. In our last hearing, we saw attempts by some members to shift the failures of the Biden-Harris administration to third-party administrators and providers. There was also yet another attempt to propagate the myth that Republicans want to privatize VA. Let me once again address this falsehood and state the position I share with Chairman Bost. Community care is VA care. It's designed to supplement VA's direct care system, not replace it. The purpose of today's hearing is to provide a refresher on the roles and responsibilities of the outside providers who are responsible for administering the community care program so that all members of the committee can refocus efforts on holding the right people accountable. This is about making sure the community care program works for veterans, not for bureaucrats in Washington, D.C. So let me spell out who is responsible for what. Third-party administrators are tasked with building provider networks and paying claims for services rendered by community care providers. Third-party administrators do not determine veterans' eligibility for community care. They do not authorize referrals, and they do not manage the transfer of medical records between VA facilities and community providers. Those responsibilities belong to the VA. When the VA fails to authorize referrals in a timely manner or delays sending the necessary documentation, veterans are the ones that suffer. We have heard countless stories from veterans who have waited months for care because their referrals were stuck in the system, or who received approval for care just prior to the expiration of that care. Veterans who have had to navigate confusing and inconsistent communication because the VA, not the outside providers, cannot get it together. One of those veterans is my constituent, Mr. Terry Barngrover, a Vietnam veteran battling blood cancer. I'd like to take a moment to describe Terry's community care experience in his own words. They just expect us to know all the rules. No one answers the phone or returns calls. We get the feeling the VA does all of this extra work, so we'll give up and not use the VA at all. And just last night and this morning, I had a veteran in my community text me about his experience at the VA with a urinary tract infection caused by a kidney stone. We can't allow these issues to persist. Veterans like Terry and the veterans we all heard from a few weeks ago in this room deserve better. They deserve a system that works for them, not against them. And that's my number one priority from my seat as the chairwoman. Today, we'll hear from VA officials and stakeholders about the steps they're taking to improve the administration of community care and ensure that the program operates efficiently and effectively so veterans can get the care they need without unnecessary delays. Thank you all for being here today. I look forward to hearing from our witnesses on how they can improve the VA community care program for the veterans who rely upon it. With that, I yield to Ranking Member Brownlee for her opening statement. The chair recognizes Ranking Member Brownlee.
Thank you, Madam Chairwoman. I am glad the subcommittee is holding this hearing today. Prior to last month, neither the committee nor the subcommittee had held an oversight hearing on community care since July of 2022, nearly 3 years ago when Democrats held the majority. I want to acknowledge and make clear at the outset that there will always be a place for community care. VA cannot provide all the care our veterans need on its own. This is especially true for women veterans needing specialized women's health and maternity care. Community care is an important part of the health care that VA provides, but finding the right balance is important, and I'm concerned that we have not yet found that balance. Today, I expect we will hear some of my colleagues on the other side of the aisle say that VA is restricting veterans' access to community care, but veterans are now receiving more than 40% of their care in the community versus only about 23% in the year before the Mission Act was implemented. Spending on community care has risen sharply over that period of time, ballooning to what some have argued is an unsustainable amount. And yet, in all that time, particularly over the last 2 years, our committee and this subcommittee have conducted limited oversight on one of the most significantly growing segments of the VA's budget. VA is on track to spend $42 billion on community care referrals this fiscal year. That shouldn't be a surprising number to everyone in this room, as more and more veterans are referred to community care every single year. But it should be shocking to everyone here that VA is sending that much money out of the door every year to a community care network over which VA and this committee have devoted very little oversight. As we will hear from our OIG and GAO witnesses, there are numerous weaknesses in VA's oversight over the performance of its third-party administrators, Optum and TriWest. These contractors, who we will hear from on the second panel, have contracts with VA worth tens of billions of dollars. And yet our witnesses from GAO and OIG have detailed in many, many reports that VA needs to perform additional oversight about how they are maintaining their provider networks and whether, and whether their providers are properly coordinating veterans' care with the VA. Worse still, we don't even know whether patients that are referred to the community are receiving more timely access to care or even high-quality care in the community. We don't know because VA has not established sufficient contractual requirements and metrics through which it can hold its contractors accountable. 3 weeks ago at a full committee hearing, my colleagues and I had the chance to hear from veterans who had difficulties accessing community care. Unfortunately, the limited witness list and hasty organization of that hearing meant that we did not get a chance to hold VA or the third-party administrators accountable for these failures, nor did we have a chance to discuss them with the experts at GAO and OIG who have done some excellent work to find room for improvement in the community care program. I'm glad we have you all here today. As I said at the hearing 3 weeks ago, I think there is absolutely room to improve the coordination of community care. On Monday, GAO published a report about this very topic, one that I requested along with some Democratic colleagues of mine. GAO found that there is inconsistency and variation across facilities in terms of how long it takes to schedule appointments, and that VA lacks a comprehensive national policy that clearly defines roles and responsibilities for local facilities. We are rapidly hurtling ahead toward a legislative hearing and a markup on Chairman Boss' community care legislation beginning less than 2 weeks from now. My colleagues and I have many questions about the current state of community care that I'm not sure can all be answered in this one subcommittee hearing. I'm also concerned that Chairman Boss' bill could exasperate existing challenges in VA community care rather than equipping VA with the resources it needs to properly operate the community care program we already have. This committee, and the Health Subcommittee in particular, has an obligation to conduct robust oversight over the health care that VA is providing, including through its community care program. I'm concerned that the committee's current level of oversight is not sufficient for us to move straight to legislating. While this hearing today is an important opportunity to hear directly from VA, Optum, and TriWest, I sincerely urge my colleagues to consider what additional oversight is needed to inform our legislative efforts. And with that, I thank you and I yield back. Madam Chair.
Thank you, Ranking Member Brownlee. The chair would also like to acknowledge that the chair of the full committee, Chairman Bost, is here with us today, and we will hear from him later. I'd now like to introduce the Panel 1 witnesses. Testifying before us today, we have Dr. Stephen Braverman, Chief Operating Officer of the Veterans Health Administration at the Department of Veterans Affairs. Accompanying Dr. Braverman, representing the Department of Veterans Affairs, is Dr. Sachin Yendi, Chief Medical Officer, Office of Integrated Veteran Care. Also with us today is Sharon Silas, Director of Healthcare for the Government Accountability Office, and Dr. Julie Kroviak, Principal Deputy Assistant Inspector General for the Healthcare Inspections for the VA's Office of Inspector General. Dr. Braverman, you're now recognized for 5 minutes to deliver your opening statement.
Okay, thank you. And before I get started, I just want to apologize up front for any coughing or sneezing that occurs during the discussion. But I thought it was really important to be here with you today. And I want to recognize Chairman Bost for joining us. So good afternoon, Chairwoman, Miller Meeks, Ranking Member Brownlee, and members of the subcommittee. Thank you for inviting me here today to discuss the Department of Veterans Affairs Community Care Program. I'm accompanied by Dr. Sachin Yende, Chief Medical Officer of the Office of Integrated Care or Integrated Veteran Care, or IVC. It's an honor to be here representing the Veterans Health Administration for the first time as its inaugural Chief Operating Officer. I'm responsible for ensuring we continue to live up to the standard the veterans expect and deserve by overseeing operations for VA's 18 Veterans Integrated Service Networks, or VISNs, and providing executive leadership and oversight to 34 program offices within the Offices of Integrated Veterans Care, Patient Care Services, and Clinical Services. It's a great responsibility, and I bring to bear the same philosophy I've shared with my teams as a leader in the Army and VA, a philosophy I call the 4 C's to success. They are communication, care of the veteran, customer service, and common sense. Over the last decade, our system has been faced with many challenges. Following my Army retirement, I joined the Edward Hines Jr. VA Hospital as its director in 2016. Frustrations with veteran access to care were at a peak and employee morale was low. Employing those 4 C's to success, we worked hard to implement the changes necessary to boost morale while keeping veteran care at the core of every decision we made. The 2018 Mission Act, passed by this committee, gave us the authority to put processes in place to ensure veterans had access to timely, appropriate care in the community when VA was unable to provide it in our direct care system. Since the Mission Act became law, VA has referred over 5.4 million unique veterans to community care providers, encompassing more than 228 million community care appointments. As with the implementation of any law, we've had to make systemic improvements to ensure timely access and build veterans' trust in our system. While serving as the director of the VA Greater Los Angeles Healthcare System, we hired and trained dedicated staff for referring and appointing veterans into community care. We piloted the VA's initial tele-emergency medicine initiative that enabled most veterans to be evaluated without costly emergency room visits and receive appropriate follow-up on specialty outpatient referrals as needed. It's now a national program. During my time as the VISN 22 director, the Phoenix VA became a model for the Referral Coordination Initiative, a nurse-led effort to connect veterans eligible for community care with the right provider for his or her needs. With implementation of the PACT Act, demand on the VA has never been greater. Since the law took effect, nearly 900,000 veterans have enrolled in VA care, with even more moving into higher priority groups, due in part to the resulting increase in service-connected disability ratings. The corresponding elimination of copays and increased eligibility for additional medical services led to more reliance on VA care that can't be met in the direct care system alone. I can confidently say that we could not meet veteran demand without the partnership and collaboration among our third-party administrators and community care providers. Still, challenges remain with care coordination and the veteran and provider experience within the community care program. A recent series of OIG inspections of VISN's community care programs, including my former network, identified several similar findings and recommendations. Those included strengthening community care oversight councils, scanning of care documents into veterans' electronic health records and referrals, and timely processing of follow-up requests for services. Based on these findings, IVC leaders, VISN directors, and VHA's Office of Integrity and Compliance are working together to execute consistent action plans across the country to address OIG's recommendations. Prior to joining the VA, I served 29 years as a physiatrist in the Army Medical Corps in both academic and operational leadership roles. As an Army retiree, a federal employee, and a deployed veteran, I have multiple options for my health care. I'm proud to say that I receive all my medical care at VA. It's the best care available. Madam Chair, Ranking Member Brownlee, and members of the committee, I look forward to working with you to continue to strengthen our healthcare system and to answering your questions.
Thank you, Dr. Braverman. Ms. Silas, you're now recognized for 5 minutes to deliver your opening statement.
Chairwoman Miller-Meeks, Ranking Member Brownlee, and members of the subcommittee. Thank you for the opportunity to be here today to discuss VA's efforts to ensure veterans have timely access to health care through the community care program. Although the majority of veterans receiving VA health care still receive their care at VA medical facilities, the number of veterans receiving care through the Veterans Community Care Program has increased greatly. In fiscal year 2023, community care represented about 40% of all VA health care. In 2018, in an effort to help alleviate long wait times for care at VA medical facilities, Congress created the most recent version of community care, the Veterans Community Care Program, expanding access to providers in veterans communities. Since the implementation of the program, the Veterans Health Administration has made numerous changes to how the program is administered, how referrals for appointments for community care providers are processed, and how the agency tracks data and information on the performance of the program. My remarks today address findings and recommendations from 7 reports that we have issued since 2018, and includes 27 recommendations that we have made to improve the community care program. Although VA has fully implemented some of those recommendations and taken steps to address others, 17 of the 27 recommendations remain open as of February 2025. There are a few areas I would like to focus on today where we believe that there are opportunities for VA to continue to make improvements to the community care program. First, we have long provided oversight of VA's appointment scheduling processes and monitoring of wait times. VA has taken some actions to address challenges both with scheduling appointments with VA and community care providers, such as establishing timeliness standards for scheduling appointments. VA has also established a timeliness standard for when a veteran's appointment should occur with a VA provider. However, VA has still not fully implemented our 2018 recommendation to establish a similar timeliness standard for community providers. Without a complete picture of how long it takes a veteran to receive care, whether that care is being delivered at the VA or through a community provider, it will continue to be difficult for the VA to know whether it's achieving its goal of providing veterans with timely access to care. Further, we recently issued a report on VA's Referral Coordination Initiative. This is a new process with the potential to transform the effectiveness of VA medical centers' processing of community care referrals and appointment scheduling. In our 2025 report, we identified challenges with the implementation of the new program, including needed improvements to the program's direction, guidance, and performance metrics. For example, we found that the regional networks and medical facilities did not have guidance that was aligned with policy, was evidence-based, nor was it timely or consistent, resulting in inconsistent implementation of the initiative and potentially impacting VA medical facility staff's ability to effectively serve veterans. We made 5 recommendations based on our findings. Second, I would like to highlight VA's oversight of community care contracts and network adequacy. Oversight of these contracts and effective monitoring of the contractor's network of community providers and their capacity to see veterans contributes to VA's ability to provide timely access to care. The Veterans Health Administration is responsible for measuring the community care contractors' performance and including network adequacy. In our August 2024 report, we reported weaknesses in VA's oversight of these contracts. Specifically, we found that the continued restructuring within the office responsible for contract oversight resulted in a lack of clarity and completeness in oversight procedures and roles and responsibilities. We made 3 recommendations to address the deficiencies that we identified. We have also found opportunities for VA to better ensure community care program network adequacy. Specifically, in our 2024 report, we found that VA's methodology to calculate network adequacy for specialty care through the program does not include all claims in their calculation. This raises concerns as to whether VA is fully assessing the adequacy of community care contractors' networks. As I have highlighted in my remarks and in the statement that we submitted, GAO will continue to monitor VA's actions addressing our open community care recommendations. We also have ongoing and future audits that will build on our existing body of work in this area, including a review of VA's medical document exchange with community providers, which we plan to issue this spring. Especially as VA has seen an increase in enrollment and reliance on VA healthcare, and the agency prepares for the next generation of community care contracts, the community care program will continue to be an important resource for expanded healthcare options for veterans and ensuring they receive timely access to care, a key goal for VA. Addressing both our outstanding and new recommendations will help VA to provide consistent, high-quality health care, regardless of where veterans receive their care. Thank you, and that concludes my statement.
Thank you, Ms. Silas. Dr. Kroviak, you're now recognized for 5 minutes to deliver your opening statement.
Thank you. Dr. Miller-Meeks, Ranking Member Brownlee, Chairman Boston, subcommittee members. I am pleased to discuss the OIG's oversight work related to VA community care. Since 2020, we have published over 50 reports that highlight the significant challenges VA faces in ensuring veterans get the care, timely and high-quality care in the community. Since 2020, we have published over 50 reports that highlight the significant challenges VA faces in veterans getting high-quality care in the community. My colleagues in the Office of Healthcare Inspections, or OHI, include physicians, nurses, pharmacists, clinical psychologists, and social workers with decades of clinical experience. This expertise allows in-depth review and analysis of not only community care's administrative issues, but also a credible perspective on how these issues affect the actual quality of care for veterans. For example, OHI's Care in the Community teams conduct cyclical VISN level reviews to evaluate compliance with VHA's community care referral and coordination processes. These reviews intentionally evaluate administrative processes that have direct impact on a healthcare provider's ability to manage and coordinate a patient's care. OHI also conducts inspections to evaluate issues specific to individual episodes of community care, again, through a clinical lens, for stakeholders to understand exactly how certain events influence the quality and timeliness of care. Additionally, OIG's Office of Audits and Evaluations has conducted multiple national reviews that highlight issues in community care related to contractor oversight, VA staffing, IT systems, and financial management processes. This oversight work has informed my testimony before this subcommittee, as well as the many briefings we give to committee staff, individual members, and VA leaders. What we have consistently found can be organized into 4 areas of concern. First, veterans may not experience timely and seamless coordinated care when they are referred to the community. Referrals designated as high risk must be consistently prioritized. Requests for additional services must be acted upon quickly to avoid interruptions to care, and results of that care must be appropriately uploaded in a patient's medical record to ensure care teams have up-to-date information and can take action that is needed. To do this, VHA must further develop administrative processes to get patients to the right provider in a timely manner, and then follow up to ensure veterans received the appropriate care. Second, VHA has inadequate oversight of community care providers and cannot ensure the quality of care that is being provided. Unlike care provided at VHA, the community care program lacks robust quality assurance processes that monitor the performance of care specific to veterans, such as screenings for suicidal ideation and military sexual trauma, as well as real-time oversight of opioid prescribing practices. For example, community care providers may not be complying with VHA's opioid safety initiative, risking the close monitoring of these prescriptions for veterans. When VA providers cannot even get timely access to basic clinical documentation detailing a community provider's management of a referred veteran, any opportunity to monitor that quality or address additional identified needs is lost. Basic qualifications of community providers must be thoroughly reviewed and verified prior to joining the community care network. Third, VHA's staffing shortages further undermine community care coordination efforts. Reliance on community providers is necessary, but as we have seen, it does not guarantee veterans will get the timely care they need. VHA must commit adequate staffing and resources to ensure community care is as seamless as it is in-house. Fourth, substandard IT systems and inaccurate and incomplete data significantly restrict VA's ability to manage community care payments. VA has a right and an obligation to recover community care treatment costs for conditions unrelated to military service from veterans' private health insurers. The OIG has found that VHA has not enacted effective processes to do this, compounded further by the pause of the program integrity tool, which is used to identify billable claims. OIG teams will continue to conduct meaningful independent oversight to ensure veterans receive the timely, high-quality care they deserve. We look forward to working with this subcommittee to advance VHA's provision of care to veterans, regardless of where it is provided. Dr. Miller-Meeks, Ranking Member Brownlee, and members of the subcommittee, this concludes my statement. I look forward to your questions.
Thank you very much, Dr. Kroviak. As is customary, I'll reserve my time until all of the members have had a chance to ask their questions. With that, I now recognize our chair of the full committee, Chairman Boss, for 5 minutes for any questions he may have.
First, I want to thank Chairman Dr. Miller-Meeks. I appreciate your friendship and the continued leadership that you're due here with the VA. It puts veterans front and center, and thank you for that. As chairman, I am deeply committed to our shared mission of improving and delivering the care and services to our nation's veterans. You've all heard me say it before, and I'm going to say it again. VA was built not for VA bureaucracy, but for the veterans themselves, and we have to remember that. That's why last month I held a hearing to learn what veterans and their family members think about community care. The witnesses put their trust in the VA, and the bureaucracy burned them in the process. Mr. Dooley, an Army veteran of 20 years, described his experience with VA saying, "I was treated like I was asking for charity and not treated as a disabled veteran that was trying to receive life-saving treatment." Ms. Locklear, a former VA employee who tragically lost her son, stated, "I believe my child would still be here today if the VA had lived up to their promise and the promises that were made to him." Ms. Diamond, a Navy veteran, struggled with access appropriate community care, and she shared this: "VA must stop its practice of rationing inpatient mental health care based on arbitrary, seemingly thoughtless guidelines." You would think that these testimonies would be sufficient for anyone to realize that VA community care reforms are needed. Some members wanted another hearing to talk about the community care and accuse us of not conducting oversight on the community care. This statement is inaccurate. Let me say that again. These statements are inaccurate. Last Congress, and I want to be very clear that all members hear this, last Congress we held 9 hearings that focused on community care. And for someone to say we aren't focused on it, we held 9 hearings. Now, I don't expect this Congress to be any different. Last week, I and 10 co-sponsors introduced Access Act because veterans have earned access to timely and quality health care, whether in the VA at home or in the community. The Access Act would codify care access standards, give veterans a say in their care choices, and provide access to urgent mental health residential care. The VA Mission Act passed in 2018 with overwhelming bipartisan support. Like the Mission Act, the Access Act does nothing to privatize VA. Now let me say that again. The VA Mission Act, like the Access Act, does nothing to privatize VA. And anyone who suggests otherwise, based on how they feel or how their party feels, needs to put a pair of glasses on and read the bill. Make no mistake, the Access Act embodies the committee's position. Community care is VA care. Community care is VA care. Community care is not a substitute, but an essential extension of VA's mission. Now, I look forward to working with my good friend, the Secretary, Doug Collins. He and I have been friends a long time. And we're going to focus on VA and its only mission. That's caring for our veterans. That's our only mission. So now my question. Dr. Braverman, what is the Trump administration doing to ensure that veterans are at the center of every VA decision?
Chairman Bost, I think the most important answer to your question is that that's already the guidance from Secretary Collins, and it's guidance that we all have and all believe in regards to the decision-making. That was also something that I put in my original opening statement, that as I've gone through my VA career, those decisions really are made with the best interests of the veterans at heart, and we will continue to do that for every decision that we make along the way.
I look forward to helping you achieve that, not only with the new secretary, but everybody that's involved. I hope that that's the mission of everyone there at the VA, and know that we're going to be working together to make that happen. Madam Chair, I yield back. My time has expired.
Thank you very much, Chair Bost. I now recognize Ranking Member Brownlee for 5 minutes for any questions she may have.
Thank you, Madam Chair. Dr. Braverman, it's really good to see you. Congratulations on your assignment here in Washington. I just have to say that I've worked with Dr. Braverman very closely over the years, and he's done really terrific work in the Los Angeles Medical Center, but for all of Vision 22, and really appreciate your leadership and seeing through the CBOC in my district as well. So thank you for that. Mr. Braverman, Secretary Collins just informed the committee today that VA doesn't expect to award a next generation of community care network contracts. This might be 2 to 3 more years before they're ready to do that. So obviously the current Optum and Tri-West contracts are set to expire. So in his letter, he said that in the previous administration, there were delayed key programmatic decisions. What were those delayed key programmatic decisions?
Well, I think the basics to that is that as we are going through the requirements process to identify, and the decisions to identify what needs to be in these contracts, we want to make sure that they're done according to acquisition standards. And that's what we will be doing moving forward. So the timeline that was identified in the letter that you received is, based on us committing to moving as quickly as possible to making those decisions and being able to award the next set of contracts by the summer of 2027.
Thank you, and I agree with your remarks as well, that community care is really important, and what Tri-West and Optum do is critically important. Those contracts are very important. Certainly GAO has identified areas where we can improve those contracts and identified a lack of formal lessons learned, a process of that. in the current, for the past and current community care contracts. So I just, maybe today is not the right day to talk about it, but I want to talk about what we have learned, do you really think, let me get to this question, do you think that we need to include in their contracts our ability to have stronger oversight in terms of, the wait times issue and other things like that built in, so that there have been a lot of recommendations, I think, that we could make the contracts better, and I believe that they perform well. I just want to make sure that we're trying to find what the right balance here is between VA care and community care, and to really find that out, we need a lot more data to make some, I think, rather tough decisions.
So we absolutely want to work together with the next contractors to make sure that that partnership identifies ways in which we can really focus on the quality of care that's being delivered within, or by the contractors, by the third-party administrators, to be able to ensure that we have a way to communicate what those wait times are, what those capabilities are, network adequacy, taking a look at those areas for improvement that have been identified in the, from the current contract administration, and building on those to make requirements that will enable us to improve those. I'll actually yield here to Dr. Yende a moment, who has some more specific information on the kinds of things that we're looking at.
Appreciate that question. I would just say we have a lot of lessons learned within our legacy contract, and based on input from both OIG and GAO. While we can't discuss acquisition-specific issues today, we would just like to reassure this committee that we are focusing for next generation on better approaches to return medical documents, a more robust.
I don't have much time, so if you can't really talk about it, I just would like to move on. Thank you. So in terms of just community care scheduling and care coordination by the VA in this process, do you think that we need to do a better job?
Now is tracking that at my level to identify what the wait times are, and then also focus on integration as we reassess what our whole IVC organization is going to look like moving forward.
And this whole offer to employees for, the buyout for leaving the organization and so forth, a lot of that, I think most of it has been rescinded now. So I'm worried about what those people who are prepared and ready to take it, and now that offer has been rescinded.
Well, in the VA, we have been very proactive in identifying exemptions from the hiring freeze and exemptions from participation or exclusions from participation in the deferred resignation program, which accounts for more than 90% of the employees that work within our field hospitals and clinics. So that I think that for the most part, our ability to care for our veterans is pretty much preserved, and I think we'll be able to continue to move forward. This is an anxious time for all of our federal employees, and we'll continue to work with them to move forward.
Thank you.
Thank you, Ranking Member Brownlee. The chair now recognizes Dr. Murphy for 5 minutes for any questions you may have.
Thank you, Mr. Chairman. I want to say thank you to all our witnesses today. I have to reiterate the chairman's comment about community care. I just don't understand the rationale of beating up on it. We don't have enough doctors in the VA. We have to refer our other patients out into the community, and making that a seamless process rather than just beating on the fact that community care is here with us is in my opinion, just ridiculous. It's a waste of time, and it's just something that the committee doesn't need to do. It's just insult after insult. As a community care provider myself, it's just ridiculous that we have it. We've come before this committee. I've been on this committee now for 5 years, and I just come up and I've heard the same litany of excuses that has gone on, and the same story about delayed care, especially in the community. And I'm hopeful that with new leadership coming in, and actually with the tenor of what's going on in Washington, D.C., that we actually get back to not only serving the people of the country, but the veterans who served us so dearly. Let me ask just a couple of questions. Dr. Kroviak, I'm in awe of all the things that you spoke about. Your testimony highlighted some reported delays in the processing of community care referrals, even for veterans with serious conditions. And I had a constituent here at our last meeting that was still waiting 9 months to get a referral. What changes do you believe, concrete changes, something that actually not to be talked about that needs to be done, should the VA implement to prevent these serious delays occurring, especially ones with time-sensitive things like cardiac disease or cancer care?
Thank you. I think the most important thing is clear policies on prioritizing the very specialties you're describing that would be automatically considered high risk, and then internal oversight that ensures that frontline staff are following through consistently on those policies and practices. And we've seen that's not happening.
Yeah, people say that we want to privatize the VA. In certain ways, I think the actions of the healthcare community in the private world should be mimicked, because it's a tone within our VA that there's no expediency to this. And again, with new leadership coming in, I think there will be now a different tenor of expediency. Follow-up question: what happened at the Buffalo VA? The staff raised concerns, but the leadership didn't do anything about it. What mechanisms now should be in place to hold the VA leaders responsible when they ignore or dismiss staff with concerns about patient safety?
So as we've said in much of our testimony and in our reports, it is clearly defined roles and responsibilities that will establish the authority that we are all looking for. If you know it is your job to follow up and make sure that your staff are performing certain activities and they are not, then you need to have the authority to hold them accountable. If you're still not getting where you need to go, you need to know to go the level above, and that is just not consistently happening.
Well, I think it needs to, and there needs to be accountability. I think that's, if one word is describing the tenor in the country right now, it's called accountability. We know that delay in care changes outcomes, period. Everybody knows, especially in cancer care. You're delayed in diagnosis, delayed in treatment, your outcome is worse. Dr. Braverman, when veterans face delays in care due to administrative failures within the VA, what processes regarding their lost referrals, miscommunications, delayed authorizations, what accountability measures are in place or need to be in place that staff and leadership are responsible for these failures? Again, accountability meaning the imperative word there.
One of the things that we have to do is identify the why for when these things happen. And is it a matter of failure to execute, failure to oversee, or just making errors because the processes aren't clear? Once we have that information at hand, we can fix the processes if that's what's going on, and then hold leaders accountable for failure to take actions when information...
Is the VA aware of something just called a basic root cause analysis?
Absolutely.
Sentinel events?
Yes, sir.
Okay, so in my world where we've had those, if God forbid there was a sentinel event where some patient was injured, didn't get the care, et cetera, there is an action team that goes in there. And that's then a zero recurrent event. It is deemed to be not to ever occur again. And sadly enough, we've heard this litany of 5 years, I have anyway, of these same things being done over and over and over again. Last 4 years, scandal after scandal after scandal, and I don't think we made 1 inch of progress towards getting better care, more efficient care for our VA. We should not be hearing these stories. Stories occur, sure. Mistakes happen because we're in a human institution. But the fact that these are recurring and over again with no improvement is anathema to what this committee should be all about. Thank you, Madam Chairman. I'll yield back.
Thank you, Dr. Murphy. The chair now recognizes Representative Sherfullis McCormick for 5 minutes for any questions she may have.
Thank you, Chairwoman Miller-Meeks and Ranking Member Brownlee for holding this hearing today. The VA has faced persistent issues with staffing clinical and administrative positions essential for managing veterans' community care. Reports from the GAO and VA OIG reveal challenges, including unreliable data for staffing assessments, inconsistent staffing practices across facilities, and inadequate staffing tools. Facility leaders lack the authority to enforce recommended staffing levels, and some question whether the suggested numbers are too high. These ongoing staffing challenges impact the effective administration of community care for our veterans. I'm deeply concerned that this problem will be further exacerbated by President Trump's recent executive order to freeze federal workforces. Dr. Braveman, what is your plan to ensure that the VA medical facility has the staff necessary to coordinate veterans' care within the community care program?
So the secretary has made it clear that we are going to have the staff required in order to do our mission, which is basically taking care of veterans.
Is there a plan as of right now?
So as of right now, there is, in that we have these exemptions against the hiring freeze for the people that are necessary in order to coordinate that care, in order to
Could you
make
tell us
the
some of the
care.
exemptions?
I have all of the medical support assistants, the nurses, the team that's associated with the provision and scheduling of these are on the exemption list. I don't know the exact number of occupations that are, on that list, but we certainly can provide that list to you.
Thank you. My second question is, since the enactment of the Mission Act, the Veterans Community Care Program has grown exponentially, straining the budget of the VA and threatening the ability of the VA to provide direct care to our veterans. In fact, the VA is on track to obligate $42 billion in FY 2025 for the Community Care Program, up from $14.3 billion before the enactment of the Mission Act. If this unsustainable trend continues, the VA will be unable to fulfill its 4 core missions, one of which is to serve a backstop for emergencies if hurricanes that affect my constituents in Florida immensely. Dr. Yeed, would you agree that it is important for the VA to achieve all of its 4 key missions?
Who was that referred to?
Oh, Dr. Yendi.
Oh, okay, sorry.
Sorry.
Yes, absolutely, Congresswoman. We do agree with you. And just to be clear, we believe that community care is an important part of VA care, and we will continue to support when veterans are eligible for community care, that they are offered community care, and veterans obviously will have the choice to determine whether they want to stay in the VA or choose community care.
But specifically, what I was asking is that, do you believe that there will be a negative impact to veterans who are the VA is supposed to be the backstop for emergency care, like hurricanes. With this exponential amount rising consistently, is there a concern for you?
We are not aware of any direct impacts on our 4th mission due to community care increase, but we can definitely take that back and give you some more details.
Would you agree that the rapid growth of spending on the community care program would potentially affect VA's ability to achieve its 4th mission, especially the 4th mission? That I guess we already discussed that. My next concern then would be, what would you propose that we could do that would kind of merge and subside the rising number of community care?
So, Congresswoman, I just want to be clear over here. Our principles when we discuss care options with the veterans are, if the veteran is not eligible for community care, our staff should be offering those options to the veterans. And then if the veteran chooses to stay in the VA, then they would get their care in the VA. But if they are choosing to go into the community, we should be able to offer that care in the community. Having said that, every day VA facilities are trying to build capacity within the direct care system to offer more and more services. A good example of this is residential treatment programs. We have increased capacity for beds within our VA direct care system, and that's how we are offering more VA care in the current system. But we just want to be clear, we don't believe these are competing. We want to make sure we follow the law in this particular case.
Thank you. I yield back.
Thank you, Representative Sherflus McCormick. The chair now recognizes Representative Van Orden for 5 minutes for any questions he may have.
Thank you, Madam Chair. Thanks for having us here today. I'm the longest-serving enlisted member of the United States military to ever get elected to Congress in the history of the nation. I get all my health care through the VA, and I love the VA. I want everybody to go to the VA who served our country. I get these rocking glasses and lacrosse. I also get seen in Toma. But when I say I get all of my health care at the VA, I mean also at Crossing Rivers Hospital in Prairie du Chien, Wisconsin, when I can't get an appointment. So again, I can't stress enough that community care is Veterans Administration care because the check is coming from there. So I just want to, because I was an enlisted guy, this is why I wanted to show you something here. These are the recommendations that were made by Ms. Silas's office, and your reports are fantastic. 50 reports is a lot. Okay, so, and these are the things that the VA hasn't done. So if you look at them sideways, they look like they're just about exactly the same thickness, don't they? So if we have the GAO working hard, sorry, I was an enlisted guy, that almost came out, and Dr. Kroviak working hard, and over years and years, since 2018, they gave you this stuff. You have 18 out of the 21 haven't been done. So it is endemic. And I've learned this as a chair of the subcommittee for economic opportunity, that we seem to keep going in these circles. You know what I mean? We got the Government Accountability Office, we got the IG doing stuff, and then it goes to the VA and it just falls into a hole. We forget about it for a while, and then another report comes. You said you did 50 reports, ma'am? 50 reports. If you're by volume to take the amount of recommendations in those 50 reports and showed us what was not acted on in any of those reports, what do you think that ratio would be? There's got to be, how many recommendations are in 50 reports? A lot.
There's hundreds of recommendations.
And so to scale, like how many do you think the Veterans Affairs Administration has not acted on?
I would be much more comfortable getting that number back to you formally,
You can
but
do enlisted
yes.
math. I'm okay with that. The point being this. There is zero accountability at the Veterans Affairs Administration, Doctor, and I'm glad you're coming in, and I'm glad Secretary Collins is here, but there's zero accountability at the Veterans Affairs Administration. And I don't have, hopefully this will change, I don't have any confidence, I mean zero confidence in the Veterans Affairs Administration to be able to plan itself even out of a wet paper sack. Because I've seen it to the tune of billions and billions and billions of dollars of waste. One example is the electronic GI Bill. The estimate from the guys at the VA that it was going to cost $25 million. You know what they're up to now? $960 million from a $25 million estimate. And Ms. Scherflis McCormick, we had this hearing the other day about the electronic service record. Wow. I mean, it's shocking. I mean, they're up to like $50 billion they think it's going to take to implement from a $16 billion initial estimate. Okay, that's unacceptable. So, I mean, it begs the question, Ms. Silas and Ms. Kroviak, you know, why do you guys even exist if you're doing this, and I mean high quality work, if it's not going to be acted on? So this is more of an encouragement, you know, senior enlisted to, you're probably a colonel or something when you got out?
Yes, I was.
Okay, there you go. So this is your senior enlisted advisor to the incoming colonel. Oh, your command is broken, and it needs to be fixed. And it won't be fixed until you hold people accountable like you would in the military. The Veterans Affairs Administration has to stop acting on a long series of suggestions. And those shouldn't be suggestions. We got to figure out a way to empower you to hold people accountable that don't follow the findings in your reports. And nothing's going to change until that happens. So I don't really have a question. I'm offering you encouragement. I want to thank you ladies for your exceptional work. And if you ever need anything, I'm really good at yelling at people. I can do that all day long. Just reach out to my office and I'll scream at them on the phone for you. Is that good?
Yes, thank you.
All right, thanks, Colonel. I yield back.
I would echo that about Representative Van Orden, and thank you very much, Representative Van Orden. The chair now recognizes Dr. Conway for 5 minutes for any questions he may have.
Thank you, Madam Chair, and thank you, ladies and gentlemen, for presenting yourself to us today. I suspect there's going to be broad agreement on this committee that community care is VA care and is necessary. And but of course, the devil's in the details and the implementation. Of course, we must, as we always do, have cost concerns as part of our deliberations. it's been noted, the rise in the use of community care, and so Dr. Braverman and perhaps Mr. Yandy may want to chime in as well. Do you have a concern about the growth of the community care program and what that might mean for the direct care program? Because what we also know is what's in our notes and has been said here at this dais is that veterans certainly want the direct care program to continue. They want to have receive their health care there. And numerous reports show that the quality of care delivered there is better than you're going to get out in the private sector. So do you have a concern about the growth of the community care program and the potential negative impact on the direct care program within the VA?
Thank you for the question. The way I would answer that is, first off, to make sure that we have a direct care system that provides, to the best of our ability, the needs for all of the veterans, so that their initial justification for care and availability for care is maximized within our system, and then continue to use the community care as that partner, as VA care, as many folks have identified that before. We are venturing on a productivity and efficiency initiative in order to try to maximize the ability to provide care in the direct care system, which will then...
Well, pardon me, just, do you have a concern about the direct care system being able to function in a way that meets the demand and the desires of the veteran community? And I think this committee, that the direct care program thrives and is there for the veterans well into the future.
I don't have concern about the ability to do that as long as Congress identifies and approves the resources that we need to make that happen.
Thank you. My next question is for Dr. Okrowiak. You know, one of the things that we're seeing in our notes, which is concerning to me, when you look at the sort of schematic they lay out for referrals, getting them done, getting people moved through a system to get care, one of the things that was noted is that there is a disconnect between what's in the Veterans Administration's regulations around referrals and the timeliness there and what the actual practice is when they get out into the community setting. Now, in your investigations, you actually go to the third-party providers, TPAs and others, to look at their processes as well as the ones in the VA, or no?
No, we look exclusively at VA.
VA exclusively. Does anybody look at the processes in the third-party community?
We don't have that authority to look at.
Don't have that authority. Okay. Well, let me bounce back to Dr. Braverman then. So, is there as you think about this next the current contract or perhaps the next contract, recognizing, and first I'll ask you, you can agree or disagree, do you recognize there's a mismatch between what the VA rules are about referral and getting and the timeliness and what actually happens in practice when people are referred to the community? Do you agree that there's a mismatch there?
I would agree that we have these set of standards that are identified in the VA access standards, and we don't have those same standards in the community care.
And so that sounds, I mean, am I right then that that's a contracting problem, the way the contracts are drafted to direct the operations of the vendors, that is Optum and what is it, TriWest, and others who are providing community care? Is that part of the problem here with this disconnect and people not getting timely care in the community?
I'll let you respond to that.
You're right. In a current contract, we don't have that requirement. But I would just add that from our standpoint, community care is a partner when VA care option is not available.
Understood.
And so if that's a backstop, and these are some of the challenges within the U.S. healthcare system. So we have to work within those confines.
Well, it sounds like it might be a contracting issue, and I do wonder whether or not, I mean, if contracts, you're not supposed to change them, but is there a way to, well, let's just say that for myself, and maybe there'll be others that disagree or agree with me, that we need to look more carefully at the contracts, the current contracts, what remedies we might have within the current contracts if people are not adhering to the contracts, and then certainly when we recontract, that we take care to make sure there's a match between what we're requiring and what they actually do. Thank you, Madam Chair.
Thank you very much, Dr. Conaway. The chair now recognizes Representative Hamadeh for 5 minutes for any questions he may have.
Thank you, Madam Chairwoman. As a veteran, I'm deeply troubled by reports of systemic delays veterans face accessing care through the VA's community care program. As mentioned earlier, we had a few weeks ago, really heard tragic stories. I mean, it's quite an emotional hearing of so many failures within the VA system and referrals to the community care program. Now, despite reforms, VA mismanagement continues to put bureaucracy over timely health care, using dishonest wait time metrics, excessive appointment cancellations, and barriers to community care referrals. The VA fails on its most basic mission, caring for those who served. My question will focus on identifying specific actions to streamline care access. Veterans deserve accountability, transparency, and flexible care options. We must focus on empowering veterans through health care choice. My first question is for Ms. Silas. What main factors drive continued barriers to community care access?
There's a number of barriers in terms of getting timely access through the community care program. One is that the process within VA to determine eligibility for the program, to identify providers in the community that are available to see veterans for care. The process itself, there's a lot of back and forth in discussing the options with the veteran, identifying the provider availability, and then working on an appointment scheduling time that works for both. And so there's a lot of back and forth that can go on during that time. It's the nature of the process. Sometimes when there's this back and forth and there may be challenges in contacting the veteran to get their preferences of times and availability, and maybe those appointments slots may get picked up by other patients, not even in a veteran or in VA care. And so there's a constant juggle of doing that within the process itself. I think one of the other issues is that veterans are competing with other patients out in the community for these appointment slots, and we know just in general in the healthcare industry that it's difficult to find providers. There's a shortage of providers. And so when you're working in that environment and the VA is responsible for ensuring that these veterans get timely care, those create a lot of challenges for them.
Would codifying access standards into law help ensure access?
I think establishing, and this goes back to our 2018 recommendation that we made, where we recommended VA establish a standard for when veterans receive care in the community. Right now, there is a standard for when an appointment is scheduled for the veteran in the community, which is great for holding the VA staff accountable for meeting that standard. But we don't have a similar standard for when the veteran actually receives care in the community. And we've had conversations with VA officials during our follow-up on these recommendations to see what actions they've taken. And there are concerns that they do not have any control over the community provider schedules and their capacity to see veterans. And so I do believe by establishing and fulfilling our recommendation of establishing a standard for receipt of care, it would at least help VA to better monitor whether or not veterans are getting timely access to care, and it would actually provide an indicator to see if they are actually meeting their goal of providing timely care.
And that leads me to Dr. Braverman. So why hasn't the VA complied with using the date requested versus the patient-indicated dates to ensure the accurate wait times that Ms. Silas just noted?
Great, I'm gonna refer that to Dr. Yende because he's more familiar with the specifics.
Our wait time calculations start from the time the service is requested. So if a primary care physician requests a cardiology appointment, that's when time zero starts, and that's how we calculate our wait times, at least in the last few years. So it is not from the clinically indicated date as you're referring to.
It just seems like there's a mismatch. I think what we need is to know what the actual wait time is and not what's most convenient for the VA. That's something that's been a frustration for so many people.
If I can just clarify, sure. Congressman, time zero, which is when the primary care physician requests that appointment, is the most proximal time. That cannot be fudged. That's when the request is made by the primary care physician. I know when people have used clinically indicated date, as you're referring to, that there may be ways to change that, but in general, we start calculating wait times from the point that request for service has been made. So I would just submit to you that there is usually no way to change that time, and that's a very conservative estimate to look at wait times.
My time is up. I yield back.
Thank you, Representative Hamadeh. The chair now recognizes Dr. Morrison for 5 minutes for any questions she may have.
Thank you, Madam Chair, for holding this hearing, and thanks to the witnesses for being here today. I've enjoyed this discussion. I think we've all learned a lot. As one of the 5 physicians serving on the subcommittee, I'm deeply committed to working with my colleagues on both sides of the aisle to ensure that our veterans receive the highest standard of care. And as an OBGYN, I'm especially focused on making sure our women veterans get the quality care that they have earned and deserve. Last week, I had the opportunity to visit the Minneapolis VA and learn about its new women's veterans clinic that is scheduled to open next year. We're lucky in the Twin Cities, our VA is pretty well equipped to meet the needs of our women veterans, but we know this isn't the case everywhere across the country. In parts of the country where women's health care isn't as readily available, we need to take extra care to ensure that community providers are filling those gaps. Ms. Silas, in its most recent report on women veterans, which was actually, I believe, in 2016, the GAO found that improving oversight of the community care program is essential to improving health care for women veterans. And we know this because many women-specific procedures like mammograms, maternity care, and gynecology are not always available at the VA. And as you know, GAO issued a priority recommendation that the VA include performance metrics for access to these women-specific procedures in its community care contracts, the rationale being that it would give VA a mechanism to work with the third-party administrators to ensure network adequacy for women's health. This recommendation was closed in 2023, but did VA ever actually incorporate any performance metrics into its community care contracts?
Thank you for the question. No, they did not. They created a dashboard to monitor access to care for women's veterans care. And while that is a good tool to monitor access, timely access to care, having contract requirements or performance metrics in a contract would have a higher level of accountability in place. And to do that, you would have to do a contract modification, which is never popular with the existing contracts. But there is a window now as VA is gearing up for the next generation of community care contracts for VA to take that into consideration.
That's great news, and you answered my next question, so thank you. Dr. Braverman, thank you for being here today. My question for you is, why didn't VA choose to follow the GAO recommendation and modify its community care contracts to implement these performance metrics for women's health, which, as we know, disproportionately referred to community providers?
Unfortunately, I can't answer the why didn't we, because I wasn't there. But we're going to take all of the recommendations that we're hearing here and identify how they can be incorporated in the next set of contracts.
That's great. So it sounds like you're open to considering this recommendation for future community care contracts.
We're open to everybody's good ideas, and some of that will be in the request for information as we move forward through the process as well.
I appreciate that. Thank you, sir. Dr. Kroviak, OIG has done a lot of excellent work identifying the inefficiencies in the community care program when it comes to getting medical records from community providers back to VA. In your observation, what are the biggest challenges facing VA, and how would you recommend that we chip away at them?
It's an incredibly discouraging but real quality of care issue for the providers who refer their patients to the community. There are delays in receiving those documents, there are delays in uploading those documents, and there are issues with uploading those documents to the correct space in the medical records where providers can access the results easily. Again, I would go back to the oversight of these functions, making sure that frontline staff understand clearly what their responsibilities are and that there is continuous supervisory oversight to ensure those are happening consistently.
Thank you for that answer. I yield my time back. Thank you, Madam Chair.
Thank you very much, Dr. Morrison. The chair now recognizes Representative King-Hines for 5 minutes for any questions she may have.
Thank you, Chair. And thank you to all of our witnesses for making it out here today. I know the winter storm is not for me coming from the islands. So I'm from the Northern Mariana Islands, and there are hundreds of veterans facing extreme limitations when accessing healthcare professionals and resources. In the Northern Mariana Islands, for context, there are 3 islands with permanent populations, Tinian, Rota, and Saipan, with roughly 47,000 people. Covering these regions on a part-time basis is one doctor who is contracted to treat veterans only 2 days a week, and one nurse. If a veteran lives in Tinian or Rota, they must travel to Saipan to visit these 2 healthcare professionals, costing hundreds of dollars in airfare alone, not to mention lodging, meals, ground transportation, and other expenses. The VHA will occasionally send specialty care doctors to the Northern Marianas, but only once every other couple of months. If a veteran from the Marianas needs more advanced, specialized care from Veterans Affairs directly, the nearest VA hospital is in Honolulu. These veterans, including many who are older and living on fixed income, must pay out of pocket to travel for care and then wait, often too long, to receive their reimbursements. Our communities have long been working to establish a community-based outpatient clinic, or a CBOC, but the threshold is 1,000, and because of the lack of care and access to care, whether it be direct or community-based care, we just see these veterans return home only to leave to look for adequate care somewhere else. And I'm sitting here and I'm listening to, my colleagues argue about whether or not direct care or community care is the most viable solution. And then I'm listening to Ms. Silas and Ms. Kroviak talk about just the issues and the challenges with both situations. And I'm sitting here having to go back home on a monthly basis and talk to veterans who, 1, are killing themselves, 2, are dying because they don't have any service at all. And I say that to go on record because too often people from the territories are not heard in terms of their needs being met. And so I thought it was important that you all hear that directly from me. Listen, I get how expensive healthcare can be, right? The challenge is not just for our veterans. We have challenge to access to healthcare for non-veterans as well. And so, what would it take, basically, for the VA to provide any type of service for our veterans that would provide some of this, would provide some of our people the relief that they're desperately seeking?
Congresswoman, I have to admit that I don't know much about the program that you're describing, and I will get some more information and get back to you.
I will refer you to a GAO report that was published in May 2024. And I think that's the problem, right, is that too often we leave these territories behind. And too often it is where these territories, that these soldiers, we're basically like a soldier-producing island. And in 10 or 20 years from now, our whole entire island's population will be nothing but vets. Yet we have to deal with all these restrictive regulations, one-size-fits-all regulations that may work here, but obviously it's not working here because we're arguing about direct services or community access services, right? And so if you can just please take note of that, and let's try to figure out how to make the situation better. Also, I have one more question. So we had one VHA administrative specialist whose duties included assisting patients in securing appointments with a part-time physician or nurse. She recently retired in 2023, and her position has been vacant since then. Can you please help us out in terms of making sure that we fill that position as soon as possible? She's the only person that provides a direct lifeline to our veterans, and she is badly needed. One person. It's all we have. All right?
If I can just add to what Dr. Braven said, places like Alaska, Pacific Islands have unique challenges that are different from the rest of the country. And we realize that sometimes the solutions have to be different.
Creative.
Yes.
Yeah.
And we work closely with TriVest, TPA partners in those regions. So will commit to looking into this as a follow-up from this hearing, and I appreciate the opportunity to look into it.
Thank you, I appreciate it.
The gentlewoman yields. Thank you, Representative King-Hines. I now yield myself 5 minutes to ask questions. As I've listened to the dialogue, which I think is very helpful to do, other questions have arisen as we've gone through this. So, Dr. Kroviak, you mentioned some metrics that are required for care within the VA, but not for care within the community. And I found that interesting because one of the things that you addressed was opioid prescribing. And so as a person who's provided community care and as a veteran, for every doctor that's out in the community, you have to access and go to the prescription drug monitoring program of your state, and you're required, in order to get your license, to have familiarity and continuing education on prescription drug monitoring. So before you can prescribe a medication, you have to go to the prescription drug monitoring, especially if it's opioid. So have you actually looked at what's required for physicians within the community that may be the same standard as what the VA is requesting?
They might very well be the same standard based on the state requirements for the license. However, we have done work that has discovered there wasn't documentation or even a reference to a PDMP query or a urine drug screen within the community when we were trying to verify that those activities.
So you haven't
were
accessed the PMDP or gone to the state to see if it's accessed?
Correct.
Okay, thank you. And then I was listening to the dialogue over waiting times, and although I may not have a difficulty with that being part of a contractual obligation, as I listened to it and heard that we don't have a standard, so a veteran tries to make an appointment for a VA, they either can't get an appointment within 30 days, or sometimes they're called back on the 29th day of 30 days to extend the timeline, and or they're greater than 40 miles away. So if a veteran could not get an appointment within 30 days and they want to access community care, but let's say the appointment at the VA is 6 weeks away, the appointment in community care is 8 weeks away, isn't the standard then the veteran? Isn't it up to the veteran to decide which waiting time they prefer or not prefer? And if they can get an earlier appointment at a VA, they can decide whether or not they want to travel the distance, or in our case, our Veterans Affairs will arrange transportation. So isn't the standard the veteran? Isn't there a standard in place now? It's okay, Dr. Yindi, you can just talk louder.
So you're absolutely right. That is exactly what the referral coordination team should be doing, is presenting that information to the veteran, and veteran should be making that choice. And the veteran chooses VA, we are very happy to support. If the veteran chooses, opts out and goes to the community, then we'll make sure the veteran gets care in the...
Yeah, and if there is a holdup in the amount of time from which a veteran requests community care, but the authorization's not given to the community care provider, so then they can't request to make, or they can't make an appointment, that then will lead to further delays. Additionally, I've got to find my document here, so I apologize. I've got all these papers because I've completely changed my testimony. Since I've been on this committee, I've heard one insult after another hurled at VA community care. And my Democrat colleagues, with all due respect, and the Biden administration have described community care as inferior to VA care and certainly argued that it's more expensive. And as I said, I'm not only a veteran, but a community provider. I know that community care is ordinarily excellent care, just like care at the VA is ordinarily excellent care. In many cases, it's specialty care that's not available at the VA or at a distance that's, manageable. Ms. Silas, your testimony also suggests that community care is often more affordable than in-house care. Your written testimony states, and I'm going to quote, because I think it's important, VA documentation shows that community care represented about 40% of all VA healthcare in fiscal year 2023. According to VHA, the department spent about $26.7 billion on this care in the same year, out of a total of $128.6 billion appropriated for all VA healthcare. By my math, 40% of the VA's healthcare is community care, but community care costs less than 25% of the VA healthcare budget. Do you agree that community care is more cost-effective than VA care?
I would have to see the details of the budget, but what the facts that you're stating are in our report and in the statement.
And this question may be rhetorical, and you may not be able to answer it, especially Dr. Braverman, who is new in this position. But the important question to ask would be, especially Dr. Braverman, you mentioned the PACT Act and the stress of the PACT Act onto being able to deliver care at the VA system. What would the cost to the VA be of all of the care currently provided in the community? So we know that it was $26 billion in 2023. What would the cost be to the VA itself?
So I agree that's somewhat rhetorical based on the information that I have. The one thing that I would identify in the calculations here is that we do have a lot of fixed costs that are not directly related to RVUs. And so the actual calculation of what it costs for the direct care system for a per patient visit is more difficult to identify.
Yeah, as is the cost to community providers as well, so I would wholeheartedly agree. Thank you all so much. On behalf of the subcommittee, I want to thank you for joining us today. You are now excused, and we'll wait for a moment as the second panel comes to the witness table. Thank you so much. Thank you very much. That's my signal. Before I introduce panel 2 witnesses, I would also like to acknowledge that the ranking member of the full committee, Representative Takano, is here with us as well, and we will hear from him later. I'd now like to introduce the panel 2 witnesses. Testifying before us today, we have Dr. Scott Kruger, Army veteran and physician, Virginia Oncology Associates, Dr. Dave McIntyre, President and CEO, Tri-West Healthcare Alliance, Mr. Ed Weinberg, President and CEO, OptumServe, and Mr. Chris Faragi, President of WellHive. Dr. Kruger, you're now recognized for 5 minutes.
Madam Chair, before we begin, I have a point of parliamentary inquiry.
So recognized?
May I state my inquiry? Both the House rules and our committee rules require non-government witnesses to submit a truth and testimony form. These forms include a question about whether the witness is, quote, a fiduciary, including but not limited to a director, officer, advisor, or resident agent of any organization or entity that has an interest in the subject matter of the hearing, end quote. It has come to my attention that both Mr. Weinberg and Mr. McIntyre indicated on their truth and testimony forms that they are not fiduciaries of their respective organizations. My inquiry is this, Madam Chairwoman. Did the majority advise the witnesses about this form and instruct them to indicate that they were not fiduciaries of their organizations? So if not, does the chairwoman find that these two witnesses who are CEOs of the third-party administrators who manage VA's community care network and hold at least $70 billion in VA contracts, that they are not fiduciaries who have an interest in the subject matter of this hearing?
I think it's important to hear from the people that are third-party administrators since we're talking about contracting, and that's one of the questions that has been brought up.
Yeah, my question relates to the truth and testimony form, which non-government witnesses must fill out. And it's important for us to know whether or not it is accurate that they are not fiduciaries. It's something that we require of all our non-government witnesses.
They said that they're not fiduciaries. We asked them to fill out and disclose the form, and they correctly filled out and disclosed on the form.
Okay, it's your
So,
determination
thank you.
there or not. Thank you.
We're now going to hear from our witnesses. Dr. Kruger, you're recognized for 5 minutes.
Thank you. Chairwoman Miller Meeks, Ranking Members Brown and Takeda, and distinguished members of the committee, thank you so much for the opportunity to testify today on the Department of Veterans Program of Community Care Medicine on behalf of my practice, Virginia Oncology Associates, and a member of the U.S. Oncology Network. This is one of the largest networks of integrated community-based oncology care in the United States. I'm Scott Kruger, and I'm a practicing medical oncologist and hematologist and medical director of Virginia Oncology Associates. I've had the privilege of providing care to many of our nation's veterans through the CCP, and I appreciate the subcommittee's attention to the critical role this program has in providing care, the highest quality and the best quality of care to our veterans. The CCP has helped bridge care gaps. However, there are significant challenges that must be addressed to enhance its effectiveness. For veterans with complex medical conditions like cancer, timely access to cancer care is critical. Many veterans experience significant delays in receiving authorizations for community care, which can be particularly detrimental for patients requiring time-sensitive treatments. In my area, it can take more than 4 to 6 months to get an approval for a mammogram and a breast biopsy. And that's due to the ineffective communication with the Office of Community Care. Furthermore, coordination between the VA and the community provider is often lacking, resulting in fragmented access to medical records, treatment plans, and follow-up care. This lack of data sharing can lead to incomplete medical histories, duplicated tests and procedures, and in some cases, delaying transmitting critical biopsy results, CT scans, MRI scans, and other vital data just delays the care even more. These challenges in coordination and communication are further compounded by the inefficiencies faced by the third-party administrators. TPAs are struggling with the high caseloads that cause delayed responses and administrative strain for both providers and patients. Although TPAs have provided our practice with the liaison to ease in some of these communication barriers, we still struggle to reach the community care office effectively. Regarding reimbursement and financial stability, we used to face significant delays in receiving reimbursements from the VA, over 5 years for a payment of one particular claim. We actually had 5 years of no non-payments for all claims. So unfortunately, when you don't pay your bills, it discourages people like myself from taking care of patients. And we want to take care of the VA patients. I myself am a veteran, and we want that to happen. It's difficult for the veterans because frequently they encounter difficulties navigating the complexities of the CPP, including eligibility requirements, scheduling, coordinating care between the VA and community providers. For instance, I saw an elderly woman in her 70s who was sent to me for an evaluation of a blood cancer. Of course, I was only allowed to see her. I could not do a CBC. I could not look at her blood. I wasn't allowed to order any testing. When I saw her, she had had a stroke. She could not walk. She had skin breakdown, and she had signs of dementia. Although I was authorized one clinical visit, I tried to arrange for her to have home care with physical therapy, occupational therapy, wound care, and rehabilitation. I set it up with 2 different home health care agencies The VA did not approve any of the agencies, and after 2 months and then 4 months, so far she still hasn't had any care. So I have a few recommendations for the committee. And basically, we need to enhance the effectiveness of our communication. Firstly, I would recognize that we need a better referral process to help expedite and implement the standardized guidelines and timeliness for approvals. This would streamline operations and reduce delays in service. Secondly, improving care coordination is crucial. This can be achieved through sharing of medical records and the use of effective communication between our platforms. As community partners, we're committed to collaborating with the VA to ensure our veterans receive the care that they deserve. Additionally, the efficiencies of the TPAs can be enhanced by establishing clear performance benchmarks and accountability measures. This will ensure that the TPAs operate effectively and contribute positively to the program. Furthermore, timely and fair reimbursement for the community providers is essential because they won't participate if there's a financial strain on their own practice. Lastly, we must strengthen and provide education and navigational resources for the veterans to help them better understand their care more efficiently and ensuring that they receive the best possible care. I briefly want to say, and I've listened to this first group of testimonies, and it would be so much easier if you just say, okay, Dr. Kruger, please take care of my patient. Here's 6 months. You can order your tests, you can order your chemotherapy, you can order your biopsy, and I will treat that veteran and get them treated clearly, efficiently, and do a great job. The current system makes me go through so much red tape before I can even start. A month and a half has gone by. So I really want to thank you for the opportunity of testifying today. I look forward to answering your questions. And I think the subcommittee has the right idea. We have to put the veteran in the center in order to strengthen the program. Our job is to work together to help the veteran to get them the care they need. Thank you.
Thank you very much, Dr. Kruger. Mr. McIntyre, you're now recognized for 5 minutes for delivering your opening statement.
Thank you, ma'am. Chairman Miller Meeks, Ranking Member Brownlee, and distinguished members of the Health Subcommittee, it's a privilege to testify before this subcommittee today on behalf of all associated with Tri-West Healthcare Alliance. For me, this is a return to this witness table, having been here multiple times in the last 10 years. To those members who I've not yet had a chance to meet, I look forward to doing so soon and working closely with you on things that matter, including in the Marianas and in my home state of Arizona. I ask that my written statement be entered into the record. Established nearly 30 years ago by a group of nonprofit health plans and 2 university hospital systems, our sole purpose since then has been supporting VA and DoD in meeting the healthcare needs of the military and veterans communities in our geographic area of operation. Nearly all who work for Tri-West either served this country or their families served. We began our work in support of VA a couple of months before the crisis of access in care in our hometown of Phoenix hit the media. Armed with a mature and robust network from our 18 years of work for the DoD, we quickly went to work to support the VA in eliminating the backlogs in needed care. Well, it's been quite a journey the last decade. Today, we serve in support of VA through the Community Care Network program across a geographic space that spans 14 states and the Pacific, comprising regions 4 and 5. And our network has delivered more than 65 million community care appointments in support of VA. Today, we have the privilege of supporting VA and serving the needs of nearly 4.7 million veterans through our network of over 300,000 credentialed community care providers, offering VA and VA access to care at over 750,000 provider locations. Each day, they deliver between 12,500 and 16,275 needed appointments, spanning all areas of specialty. And we pay their bills in 3 days to an accuracy rate in excess of 99%. We've been working a number of initiatives collaboratively with VA in our markets to demonstrate the art of the possible through a tighter partnership to strengthening VA and allowing them to fully leverage us for the benefit of veterans that reside in their area. And I think of 2 markets that highlight that promise, the Valley in Texas and Montana, as they're leading the way. Second, we're working with many of the VISNs and VAMCs in our area who have a responsibility to try and make things more efficient in terms of how we're doing our work. All with an eye towards how do we do appointment scheduling more effectively between us and what provider changes need to be made that impact care delivery in a positive way. Fourth, many more collaborative initiatives have been underway in our geographic area of responsibility, all with the goal of effective refinement to our collective performance. In fact, next week, we in the VA team are gathering for 2 days to discuss what we want to add to our collective list in our further quest to improve collective performance. Lastly, I would like to thank this committee and the leadership for your focus on fixing once and for all the rule that forces us to reject provider claims that arrive 6 months after the date of service rather than allowing 12 months, as is the case for TRICARE, Medicare, Medicaid, and the private insurance market. It is beyond time that this gets fixed and that we execute properly and promptly the change once it is law. We're proud of the progress that we have made together over the past decade, and it's been painful for many of us, but we have made progress. Yet we all know that work remains to achieve our true potential of delivering fully for this generation's heroes. And as we know, this committee is focused on the refinements necessary to ensuring that what was envisioned in the year-long bipartisan effort that led to the passage of the Mission Act and the authorities and resources that have followed in the years since is going to be delivered on. From all of us associated with Tri-West, we look forward to doing our part in collaborating with this committee to respond to those adjustments believed necessary to achieve our collective potential so that our nation's heroes, their families, caregivers, and survivors receive that which we owe them.
Thank you, Mr. McIntyre. We have votes at 4:30, so I'm going to remind our witnesses to be within their 5-minute time frame. I'm also going to remind all members that I will be gaveling them out at the 5-minute interval. I thank you. Mr. Weinberg, you are now recognized for 5 minutes to deliver your opening statement.
Chairwoman Miller-Meeks, Ranking Member Brownlee, Ranking Member Takano, and distinguished members of the subcommittee, good afternoon. And thank you for the opportunity to discuss OptumServe's role as a third-party administrator for the VA-CCN program in Regions 1, 2, and 3, where we've been supporting veterans' choice and access to care for nearly 6 years. As a combat veteran, retired Army officer, and the proud father of a soldier, I have a deep understanding for the sacrifices made by our nation's veterans and their families. I am deeply connected to our purpose, and I'm also committed to the success of the entire VA health ecosystem. But I certainly can't do it alone. At OptumServe, I'm humbled to be surrounded by 5,000 great Americans, many of whom have served in the armed forces or in the VA, or as military spouses and caregivers. Through the VA-CCN program, we have the privilege of supporting nearly 6.5 million veterans across 36 states, Washington, D.C., the U.S. Virgin Islands, and Puerto Rico, and we are making a clear difference. With our robust network of providers, nearly 2.4 million credentialed care sites, We have facilitated over 159 million veteran care visits since we started healthcare delivery in 2019. We also know that building the provider network is only half the story. It's the maintaining of the network for our veterans that really matters. And our success in sustaining the network is in large part due to adjudicating and paying provider claims in 7 days on average, far exceeding the requirements set forth by the VA. Another critical factor in our success story is the collaborative relationships that we've developed throughout the veteran community. We enjoy strong relationships with VA at every level to ensure veterans have access to the right care whenever and whenever they need it, meeting at least monthly with each of our 109 VA medical centers and visits in our regions. We hold quarterly program management review meetings with VA Central Office to ensure proper oversight. And we do in-person updates and engagement with our military and veteran service organizations. And we have consistently worked with Congress ensuring that you and your staff receive quarterly updates on the important work that we are leading. One of the many ways we manage these relationships is through veteran experience officers who provide boots-on-the-ground support at each VA medical center, and through our provider advocates who work between VA and community providers to ensure veteran care needs are being met. At OptumServe, we remain purpose-oriented by keeping the veteran at the center of everything that we do. While the total numbers of our impact are interesting, I always remind my team to focus on the power of one. Each phone call, every pharmacy transaction, every response to a VA staff member, that's where the magic happens. And while we are laser-focused on our stated requirements, we also seek ways to help the VA system work better for everyone. One such area is in medical records retrieval. While we fulfill our obligations of educating providers on medical record return policies, we don't stop there. We have developed mechanisms for VA staff and providers to escalate if they are not receiving their records back in a timely manner. Additionally, we collaborate with VA leadership to identify ways we can improve existing processes. For example, we are actively engaged in a Vision 1 pilot with the goal of improving the exchange of medical record documentation between community providers and the VA. I am deeply grateful for the opportunity to share OptumServe's unwavering dedication to veterans through the VA CCN program. We look forward to our ongoing collaboration with the VA, with this subcommittee, and all of the partners that we work with. We are making a difference, and my belief is that we will always be better together. Thank you again for the opportunity to be here today, and I look forward to your questions.
Thank you, Mr. Weinberg. Mr. Faraji, you are now recognized for 5 minutes to deliver your opening statement.
Chairwoman Miller-Meeks, Ranking Member Brownlee, and distinguished members of the subcommittee, thank you for the opportunity to speak to you today. My name is Chris Faraji, and I'm the president of WellHive. We're a healthcare software company dedicated to modernizing the VA's approach to community care scheduling. Our technology isn't theoretical. It's real, it's proven, and it's successful. It was purposely built to address the VA's longstanding inefficiencies in scheduling and ensuring veterans receive the care from the right provider at the right time. This is why VA contracted with us in 2023 to deliver this technology nationwide. The issues we're tackling is one we all recognize. Veterans are patiently waiting to get the care they need. Right now, scheduling a VA community care appointment is like booking a flight before Expedia or Travelocity even existed. Imagine needing to fly across the country, but instead of searching online, you have to call each airline separately. You're waiting on hold, you're checking availability one by one, repeating this process until you finally find the flight that works. That's exactly how the VA community care scheduling system works today. Medical support assistants, also known as MSAs, have a hard job. They spend hours making calls, waiting for responses, and manually piecing together the appointment availability while veterans are waiting. And this is where things change. With the external provider scheduling, it allows schedulers to instantly see real-time appointment availability across multiple provider groups in the community and book on the spot. No more phone tag, no more unnecessary delays, just fast, efficient scheduling that ensures veterans get the care they need when they need it. And we know it works. At sites using EPS, MSA schedulers book up to 4 times as many appointments per day compared to the outdated manual methods. But the most compelling proof comes from those from the front lines. One scheduler calls EPS a godsend, saying, "Before I spent hours tracking down appointments, now I see them instantly. The time saved is making a world of difference for veterans." Another shared, "Before EPS, I would schedule an appointment only to find out later that the provider wasn't available, forcing me to reschedule. Now I know exactly when and where the veteran can be seen, avoiding unnecessary delays." EPS is directly reducing wait times. The current average wait to schedule a VA community care appointment is 31 days. With EPS, and even without the critical integrations into systems like HSRM or Console Toolbox, that wait drops by 33%. And in some locations, the improvement is even more dramatic. For example, Columbia, South Carolina, their wait times have dropped by 52%. In Dallas, Texas, the wait times have fallen by 46%. So yet, despite these results, EPS remains optional. This means many schedulers are still relying on outdated methods, and even at sites where EPS is fully available, more than half the appointments are still booked manually. We are encouraged by the direction of this Congress, the new administration, and Secretary Collins, who has made it clear to the commitment to ensuring veterans receive the care they deserve. We at Wellhive stand ready to work side by side, Secretary Collins, Congress, VA, to ensure an aggressive rollout of EPS. Technology isn't the obstacle, bureaucracy is. The solution is simple. Let's just cut through the red tape, and let's fully integrate EPS into the VA's mission across the country. Before concluding, I'd like to briefly address some of the comments from the first panel. There is obviously a pattern of scheduling that is inherent into the conversations of today's questions. Ms. Silas mentioned some of the nuances that these schedulers and veterans are facing when they're not able to have that information at their fingertips. They're waiting. They don't know. They'll get back to them. They make these telephone calls. And they also made a comment about the veterans competing with non-veterans for these appointment slots. But what the EPS Wellhive platform has been able to do is provide and equip these schedulers with that information so that, hey, if there is a provider that doesn't have availability, they're going to see it. But if the provider does have availability, they'll also be able to see it. So they're not wasting time calling providers that do not have availability in the first place. So, and another point that I would like to make with my remaining time is that, from Dr. Morrison, you had made mention of women's health. We're really excited because this week we were able to activate and provide mammograms where they can now be scheduled. So it's not just providers, but it's mammograms. And in addition to that, we also have imaging. I thank you very much for the time, and I look forward to your questions.
Thank you very much, Mr. Faraji. I now recognize the ranking member of the full committee, Representative Takano, for 5 minutes for any questions he may have.
Thank you, Madam Chair, for this courtesy. I have a question for both Mr. McIntyre and Mr. Weinberg. You are both paid capitated rates that are calculated on the basis of how many veterans are directed to your networks. So that means the more veterans referred to you, the more you're paid. Is that right, Mr. McIntyre?
We are paid in administrative.
Just answer the question. The more they're referred to you, the more you're paid. Is that right?
Yes.
Yes, Mr. Weinberg.
Congressman, we get paid if there's a paid claim.
It's a very simple question. The more veterans are referred to you, the more you're paid. Is that right?
That's correct for
Thank you. Do either of you conduct assessments of the quality of care delivered by specific providers in your networks?
Yes.
Yes, we do.
You do. And you make this information available to veterans?
Make the information available to VA.
Mr. Weinberg?
We as well make it available to the VA.
Well, I'm going to tell you that VA facilities are regularly rated on quality measures, and this public is provided to veterans and the public. I find it extremely hard to believe that you actually do these assessments since you do not require your network providers to return medical records to you or the VA. I heard about all the pilots, but in general, you do not require this. So I don't know how you could be assessing the quality of care. What would you be even using to assess the quality of care? Either one of you have Mr. Weinberg?
Well, thanks for the question. what I would probably start with is we've got a credentialed network, so quality starts with verification of state license. It also, board certifications, education, so we do verify that with all of our providers.
Well, thank you very much for that, but I don't believe it's the kind of rating and assessment that VA does. I know that United Healthcare Group has plenty of experience reviewing medical records when it is deciding whether to pay a claim or make a patient prove medical necessity. And it astounds me that there is no conditioning of payment on the return of records for veterans community care. Do you conduct audits to identify whether or not your network providers are opportunistically billing VA for additional services or requesting additional authorizations rather than referring veterans back to VA for coordinated care? Mr. McIntyre?
Thank you for the question, sir. When we started the
Do
work,
you actually do audits regularly, systematically, of your network?
yes, we do.
You do.
And if
Mr.
I can
Weinberg.
a- if
Mr.
I can
Weinberg. Mr.
answer-
Weinberg, please. Can we claim my time?
Congressman, we not only audit, but we are audited by independent external auditors quarterly, and those data are all provided back.
I would be interested in knowing whether there's any opportunistic billing. Mr. Weinberg, this question is for you. How many veterans currently enrolled in United Healthcare Group's Medicare Advantage plans are also receiving care through VA's community care program?
Congressman, I appreciate the question. I don't know the answer to how many.
Well, thank you. I would hope that you would get that answer back to the committee within a week.
We'd be happy to do that.
United Healthcare Group operates one of the largest Medicare Advantage programs in the country, so it is collecting premiums for veterans, and through its Optum subsidiary is collecting payments from VA under the community care program. Veterans receive the care once, but United Healthcare ostensibly is getting paid twice. Do you think the federal government and taxpayers are overpaying because of this double billing practice?
Thank you for the question, Congressman. No, I don't. I believe that veterans have choices for their health care, and they've earned the right to use the VA as well as any other benefit they've
It's
earned.
really non-responsive to my question because it's really about the double billing. United Healthcare is receiving Medicare Advantage premiums, but yet they're also you're also receiving money from the community care program. And my question was, isn't that double billing?
Congressman, we don't view it that way. We view it as the administrative fees that we need to manage both programs.
I see. Well, Mr. McIntyre, just because you found a loophole to collect from both Medicare Advantage and VA for the same veterans care doesn't make it right. It makes it a taxpayer-funded windfall for your company at the expense of veterans and American people. Mr. Weinberg, how much revenue does Optum United Healthcare Group and for both of you, how much does it generate from the community care contracts over the past year, 5 years, or the entire time you've held the community care contracts, Mr. McIntyre?
I'll be glad to get you that information, Congressman. And I'd say that
Mr. Weinberg?
we used to require.
Mr. Weinberg, how much money would you say?
Congressman, can you repeat the question?
How much money have your contracts generated from the community care program?
I mean, if you want the specific number, Congressman, I would prefer to come back to you with that for the record.
Okay, tens of billions of dollars?
I would say yes, and I would also remind you, sir, that many of those dollars are pass-through dollars, so they are paying the provider directly. They're not coming back to the
Thank you. I yield back.
Thank you. The gentleman's time has expired. The chair now recognizes Representative Hamadeh for 5 minutes for any questions he may have.
Thank you, Madam Chair. Now, as I sit here in this committee and other committees and on the VA, I'm deeply concerned by my Democrat colleagues' attempt to scapegoat community care providers caused by VA mismanagement. I feel as if too often some of our colleagues are focused on protecting the bureaucracy and not veterans care. Now, as outlined in the staff memo titled "On Most Alarming Aspects of VA Document Review," efforts to mitigate community care aim to trap veterans in a broken VA system, limiting choice and access. Now, Madam Chair, at this time, I ask unanimous consent to insert our staff memo into the hearing record.
No objections, so
Rather than attacking partners trying to serve veterans, we must identify solutions to cutting bureaucratic red tape and empower veterans through accountable, flexible care options. They deserve nothing less. Now, my question is for my fellow Arizonan, Mr. McIntyre. During COVID, you took over appointment scheduling responsibilities from the VA, correct?
Yes, sir.
And could resuming centralized scheduling improve access?
Used to do the things that were to the right of the line of demarcation, and the VA did the work to the left, and that worked. The current system could be refined, but that worked. The second thing that we did is we did not, back in the day, pay a provider's claim until they submitted their medical records. And we paid the claims in days. And Congress felt that it was problematic because some providers were complaining about that requirement. But 85% of the doctors were providing the medical records to the system under that approach.
What obstacles have you faced building robust provider networks due to burdensome VA administrative barriers?
We haven't faced problems in the development of network because of that. It's maintaining this network that's challenging, and we're working together with the VA to try and make sure that those challenges are addressed in the markets where we face them.
So it seems like you guys are working together right now?
We're trying.
Okay.
On both sides.
That's good to hear. Now, Mr. Weinberg, what specific steps can the VA take to improve the referral process?
Congressman, great question. I do believe that a lot of what I heard on panel one in that discussion was on point. We're talking about standards, not standardization. I think we're reminding ourselves that healthcare is local, and I believe that there's got to be accountability in the system. So we need to be measuring, we need to be tracking, and we need to be holding folks accountable.
Thank you. I yield back.
Thank you, Representative Hamadeh. The chair now recognizes Representative Brownlee, Ranking Member Brownlee, for 5 minutes.
Thank you, Madam Chair. Mr. Weinberg, I was concerned to read in Dr. Kruger's testimony that the reimbursement rates his practice receives are often lower than those offered by Medicare. Is Optum reimbursing providers that are lower than Medicare rate?
Congresswoman, thank you for the question. We do follow the strict adherence of the payment rates that are given to us by the VA, primarily for medical care. That would be in line with CMS.
But the Mission
CMS
Act
rates.
clearly states that you must be paid by Medicare rate. So I'm just making sure that that's what you're paying. So, Mr.
Medicare
Kruger,
rates.
is that inconsistent with what you understand?
So the problem is the VA initially, and this has been happening for about the last 7 years, it got better about 2 years ago, basically didn't pay any claims for over 5 years with multiple submissions and multiple fights between our local VA and the VA in Salem. When eventually it was paid, they were paying it on the current rates when they approved the bill,
I see.
even though the treatment was done 4 years ago.
I see.
So the drugs then
So that has smoothed out?
it has smoothed out.
Okay. And so again, maybe you're clarifying another question that I had, because Mr. McIntyre is saying that he's providing a 3-day turnaround on reimbursements, and you were saying sometimes it's up to 5 years. So there was a lot of inconsistency there, but you're saying now that that reimbursement process has improved significantly.
It's improved significantly over the last 6 months. What has helped significantly was we've been giving a liaison that we can talk to an Optum, and they are helpful with the billing. But they don't really get involved with ordering the care for the patient. That's up to the VA Community Care Office.
Thank you. So to Optum and TriWest, we, in the first panel, we talked about the contract, the delay in the contract, possible additions to a future contract. Would you have any issue in terms of transparency around wait times within community care?
I believe personally that there needs to be accountability and transparency on both sides with regard to wait times. And currently, in our area for last year, it was an average 7 days to schedule once the appointment request was given by VA, an average of 20 days to be seen, and an average of 15 days to be seen at the date preferred by the veteran.
Right. So, but what we would like to see is really, you know, on sort of a monthly basis to know what's happening in direct care with the VA and what their wait times are and what your wait times are, not so much the averages over, you know, a long period of time. But that would not be a problem.
We had talked about years ago the longitudinal look at this, and you need to be doing that. You know?
And Mr. Weinberg, do you agree, or?
Congresswoman, I would agree. We do provide hundreds of deliverables to the VA, which would include, performance for our network adequacy. The only other thing I would add is that I think it's essential if we're talking about access and choice for veterans, they need to be able to see those data so they can make the most informed choice.
It is clear to me that this EPS system that has been described today is music to my ears, honestly. I think we need to do a lot of technology outside of the VA to bring it in. But it seems as though this could be a huge improvement in terms of community care scheduling, although it's optional. So did the VA decide that it was just going to be optional, or did you decide that it should be optional? I'm trying to understand why it can't be universal across the board, because it seems like it really would improve that process.
Sorry, was that question to me?
Well, I think it needs to be.
Well, I can answer it. I mean, it's actually not coming from the vendor, or it's not coming from the TPAs. It's coming directly from VA. The VA
okay, so it's VA that is saying.
No, there's not been any sort of directive to be able to use this.
But for Optum and Tri-West, you haven't asked VA to make it optional. That would be preferable to you.
No, ma'am.
And would, Dr. Kruger, would physicians or providers have a problem putting out their schedules in the ether?
For us, that would be a little bit of a challenge because different oncologists specialize in different areas. The vendor may not know that. Basically, if they send us a consult, they will get an answer in 48 hours. All oncology is seen within 24 hours of the appointment. All hematology is seen within 3 days. That's
Thank
our
you.
working.
I yield back. Sorry, I didn't.
Thank you. If you have other questions, please submit them in writing. We'll make sure that they're answered. The chair now recognizes Representative King-Hines for 5 minutes for any questions she may have.
Thank you, Chair. I just have one quick question for Mr. McIntyre, since you provide coverage for the Marianas.
Yes, ma'am.
I know that access to health care, just for the average ordinary citizen, is a challenge because of the amount of providers that are available out there, whether it be mental health or any type of care. Can you just share a little bit if you're having challenges with ensuring that you have an adequate pool of providers to be able to provide the care that we're trying to give to veterans?
Yeah. For your area in the country, ma'am, I made 2 visits to Tinian and Rhoda and to the Marianas. And we have the providers in that community under contract. But as you well stated, it's important to make sure that there's a footprint at some of those places like Tinian that doesn't have health care to be able to allow circuit riders to come in and out of that area to meet the needs versus people traveling. And so we look forward to working with you and with the VA to pick up a topic that we worked on 5 years ago.
Okay. We'll speak offline. We'll have the office reach out. Thank you.
Look forward to it.
Appreciate it. I yield back, Chair.
Thank you, Representative King-Hines. The chair now recognizes Dr. Morrison for 5 minutes for any questions she may have.
Thank you, Madam Chair, and thank you to the witnesses for being present to answer our questions today. During the first panel, I think you may have heard me ask witnesses from VA and GAO about including performance metrics that would track access to women's specific procedures and community care contracts. Since women's health care is disproportionately referred to the community, we need to make sure that our community providers are delivering this essential care. And they indicated that they thought it would be an effective way to improve care for women veterans. Mr. Weinberg and Mr. McIntyre, what do you think about this sort of contractual requirement in TPA contracts?
Congresswoman, thank you for the question. Again, I think that transparency is really kind of rule the day here. I think that the more we know and the more veterans know, the better choices they'll be able to make.
Agree, and I think tracking standards and making sure that we're being transparent about where we are juxtaposed to the standards makes a lot of sense.
Appreciate that. Thank you, gentlemen. Back to the two of you again. We know that community care is an essential piece of the puzzle, but we also know that, in general, veterans prefer VA care, in part because many VA providers are veterans themselves and understand the military and veteran experience. I've trained at a VA during my early medical career, and I can tell you that even those of us who aren't veterans are still required to take military cultural competency trainings and a myriad of other trainings that are sensitive to veterans' needs. Do you know what percentage of your network providers have completed optional trainings on military cultural competency, suicide prevention, and opioid safety?
Congresswoman, thank you for the question. While I don't know the exact percentage, what I can tell you is that we do have a pretty robust suite of training offerings, to include a partnership we've just formed with Psych Armor, who offers additional ones. The other thing that I think is really important as we think about incentivizing providers to take the trainings is to actually start to offer CEUs. And so we've done that with a couple of courses now, one for opioids and the other one on suicide prevention, and we've got a few others in the queue as well.
We also have a similar suite of products and content to include VA-provided content, and we've been working with Psych Armor for 5 or 6 years. I would say that in the area of opioid training, the question is, do the providers need to take VA-specific training, or is it sufficient to use their state licensure requirement, which is required of all of them? So I think, to the last panel, it'd be worth all of us taking a look at what reality is and what's occurring in that place.
Thank you. And then one final question, Mr. Weinberg. These same trainings that all VA providers are required to take are optional but available through Optum, right?
That's correct, Congresswoman.
Is there a way for a veteran to know if one of your providers has completed trainings about suicide prevention in that spirit of transparency?
At this time, there isn't. We aren't required to transmit those level of data over in our provider data file, but I think it's a great point, and it's something that we would be willing to talk through if it becomes a requirement from the VA. I think it, again, gives more transparency to the veteran as they're making their choice.
Appreciate that, and thank you for your service. I yield back.
Thank you very much, Dr. Morrison. I now recognize myself for 5 minutes. Dr. Morrison, thank you for that excellent question I'm going to pose to the VA, that I would also like to see the VA stats on how many veterans ask if the VA provider has completed and done VA-specific care, whether it's opioid, suicide prevention, mental health, or any of the other variety of things that continually get brought up in this hearing as a difference. Again, being a veteran who doesn't access VA care, and I prefer to get my care in the community, and a community provider, we want the best care for veterans where veterans are located. And Mr. Faraji, I'm going to actually go to you first, because the reason you're here is actually the point that Ranking Member Brownlee made. So given the success of External Provider Scheduling Program, or EPS, do you believe EPS should be adopted across all VISNs to eliminate the inconsistent care scheduling veterans currently experience?
Thank you for the question. I absolutely believe that it should be rolled out across the country and have that equitable care, so that there are veterans that aren't able to experience EPS because it's not live in their sites. And so they're not being able to take advantage of the efficiencies that the platform is already doing today for the sites that do have it, by decreasing wait times, allowing the schedulers to be even more productive.
And I have no fiduciary interest in you or your product, but however, would such a scheduling platform be beneficial even within the VA system for scheduling appointments?
I'm sorry, what was that?
Would it be beneficial even within the VA, not just in community care, to schedule such a platform to schedule appointments?
Yes, that's correct. We actually did a pilot in January of 2023, where we actually integrated into Vision 7 and 8 with 15 instances of Vista, and we were able to demonstrate to be able to see across those Vista instances and be able to compare that availability with those providers. And the goal would be to then add on the community care network to be able to give you that apples-to-apples comparison, which the comment that you made earlier about it's up to the veteran if you want to have in the VA care or community care, because they're both at the point where they're further out, right? So being able to have that.
So thank you for saving me. That was a big faux pas. I'm never supposed to ask a question I don't know the answer to, and I didn't know the answer to that question. So thank you that it worked out well for us. Dr. Kruger, could you share some of the difficulties you have experienced with sending and receiving medical records to the VA?
So thank you. We do send the records. I don't know where they go to, but we do fax them. That's the only way we're supposed to send them. Our communication systems and computers do not talk to the VA. In terms of receiving records, the VA in my community says that we are their last priority, and they will get around to it when they can. So the difficulty that I have of taking care of patients is that if I have to do a CAT scan, the VA determines where it's going to be. I don't know where it's going to be. I don't know where to get the results. I have to wait for the VA to tell me it's been done and to give me the results. Very difficult if I find out it's been done at one of the military hospitals, that I'm told it's a HIPAA breach, even though I'm the one who ordered it. It's really the VA who ordered it, and I can't get the results.
Thank you very much for that. So it sounds like there's some work we have to do on both ends on the medical records and also to have interoperability, which may be beneficial rather than faxing. Mr. Weinberg, how do delays, I know it was Dr. Braverman who had the cold, but I'm the one that's stuttering. How do delays in VA referral authorizations impact your ability to provide timely care for veterans?
Yeah, Madam Chair, thanks for the question. You know, one of the things that we try to do is make sure that there's as much coordination between us and the VA as possible. I go back to my statements about relationships at the central office level, visit level, VA Medical Center office, to include sitting down and doing network adequacy meetings every single month. And so, you know, the impact for me, it's not about our organization, it's really about the veteran. And so what we're trying to do is help make that go as fast as possible.
Thank you. I yield back. Ranking Member Brownlee, would you like to make any closing remarks?
Brief, but I think that this has been an important meeting, and I'm glad you have called it. I think there's still a lot for us to learn and to understand, and now that we have a delay in this contract, I hope that we can take the time to think about what can be included in the contract to improve services for our veterans. I think this EPS system, I think should be universal across the board, and if it can be internal within the VA, I think we need to do that. I mean, this could be a huge, huge improvement just by doing this. But I think, we still need I think we still need more hearings and a deeper understanding of where the right balance is. This is what I continue to say over and over and over again in these hearings, is the right balance between community care and VA care. And, where is that balance? I took offense to Dr. Murphy saying that I'm being critical, always continuing to be critical about community care. That's quite the opposite. I believe that the community care is an essential part, which I even said in my opening comments, but community care is essential to the success of the VA and providing services to our veterans when they need it and where they need it. So I just think that we've got to be clear about the direction that we're going in and trying to find that right balance. I mean, I would wonder from really the two providers here, Optum and Tri-West, if you had a huge increase, a very significant increase in patients, over a period of time, is that something that you could actually handle? I don't know if you. Thank you, but that's a question that I would really like to have answered, and I'll yield back.
Thank you very much, Ranking Member Brownlee. I'd like to thank everyone for their participation in today's hearing and for the great discussions we've had on this important topic. I also would say I would be happy to accommodate Ranking Member Brownlee on having more hearings on community care and on this topic, because as I stated earlier, our veterans' biggest barrier to receiving the care they deserve should not be the VA itself. Today's hearing reinforced the importance of the clear roles and responsibilities within the community care program and the need to focus on solutions that work for veterans, such as what we heard today with Mr. Faraji and Wellhive, and it focuses on the veterans and not on the people who run the system. I look forward to working with Secretary Collins and the VA, Dr. Braverman especially, to ensure the high-quality care is delivered to our veterans. The complete written statement of today's witnesses will be entered into the hearing record. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and include extraneous material. Hearing no objections, so ordered. I thank all members and the witnesses for their attendance and participation today. The hearing is now adjourned.